Can you all hear me? Yes. Good morning, everyone. Well, it's a true pleasure to be here. I'm Maria de Jesus with my colleague here, Deanna Ware, and others, Department of Medicine at Georgetown University, and I myself am at the Center on Health, Risk, and Society at American University, along with other colleagues, Michael Planke and others who contributed to this paper, Disrupting the Path from Depression to Loneliness, Multilevel Resilience Among Older Sexual Minority Men Living with or Without HIV. So we know that, by way of background, older sexual minority men, which I'll refer to as SMM moving forward, living with HIV experience a higher prevalence of loneliness and depression, as well as other psychosocial conditions, as we've talked about, and cognitive conditions, are more likely than non-SMM to face stigma, discrimination, and marginalization, and that despite these negative psychosocial conditions, SMM exhibit resilience. So we wanted to explore this idea further in this paper by first thinking about resilience as a multi-level variable. So here we're defining resilience as the process through which an individual makes use of available resources to positively adapt following an experience of adversity. By internal resources, we're referring to more the individual level, character traits, physical, cognitive, emotional states. By external, we're thinking more at the interpersonal and community level, social, family influences. So in this paper, we operationalize multi-level resilience in three levels. So individual level, qualities such as personal competence, stress tolerance, acceptance of change, and other positive personal attributes. At the interpersonal level, we looked at issues related to general support or specific supportive behaviors from people in their social networks. And community level, the community members' ability to lean on collective resources, again, at that community level, and social belonging to promote their health and well-being. Our aim was to determine whether this multi-level resilience mediated the bidirectional relationship between depression and loneliness among older sexual minority men living with and without HIV. Our hypothesis is that there would be a positive bidirectional relationship between depression and loneliness that would in turn become weaker with the inclusion of this variable of multi-level resilience.
So our data comes from the Multi-Center AIDS Cohort Study, which is a long-standing longitudinal cohort study that examined the natural and treated history of HIV among a cohort of sexual minority men in 4 U.S. cities. A subset of these men participated in the Understanding Healthy Aging in Men Who Have Sex with Men, which is a sub-study of the MACS conducted over 6 waves between 2016 and 2019. The purpose of that sub-study was to identify and understand psychosocial resilience that promote healthy aging in middle-aged and older sexual minority men living with and without HIV. Okay, so our analytic sample included 1,264 participants, is about split 50-50, with data on depression symptoms, loneliness, and resiliency between 2016 and 2019. I listed the time points here so you can kind of get an idea of the time that we collected this data. The depression symptoms was assessed using the Centers for Epidemiologic Studies Depression, where scores greater than 16 indicated the presence of depression symptoms. And then loneliness was assessed using the UCLA 3-item loneliness scale, where scores greater than 6 indicated loneliness. Both of these measures were obtained at time 1 and time 3. Multi-level resilience was assessed at time 2. We used 3 different scales to represent each level, multi-resilience level. At the individual level, we used the Global Resiliency Scale, which is a 14-item scale. It's on a 7-point Likert, and it assessed the participants' ability, the participants' attitudes about life, and included statements such as, my belief in myself gets me through hard times and that I am determined. So those are some of the statements. Relationship structure, which is the interpersonal level, a 9-item scale that assessed the attachment patterns of close relationships and included statements such as, I am afraid that other people may abandon me, and another statement, I find it easy to depend on others. We reverse coded all negative worded items. For the community level, we use the psychological sense of community adapted to the gay male community, and it included questions such as, how much do you feel you get help from gay men when you need it, and how much do you feel like you're a member of the gay community? Our covariates included HIV status, age, race, ethnicity, and education level. For our statistical analysis, we used descriptive statistics on measures and the covariates by HIV status. Then we used exploratory and confirmatory factor analysis to identify the multi-level resiliences at time 2. So EFA-CFA, if you're not familiar, allows us to consolidate a large number of items from a scale into just a few easily comprehensible factors. So the factors were explored. We used EFA first on 50% of the sample as a training sample, and then we verified them using confirmatory factor analysis on a testing data set. Okay, and we included those factors in a longitudinal mediation model. We actually had two different models. The first panel will show you the depressive symptoms. We have an unmediated model from loneliness at time 1 to depression at time 3. And then below that, you'll see the mediated model where the resiliencies fit in. And then the same for the loneliness, just in reversed. So our median age was 61. The majority were white, non-Hispanic, with at least actually similarly high education attainment, so 85% with with at least some college education. Our depressive symptoms at time 1 and 3 were 18 and about 19% respectively. Loneliness was at 28 and 27% at time 1 and time 3 respectively. And then comparing HIV, participants living with HIV to participants living without HIV, we saw that participants living with HIV were younger, less non-Hispanic white, with similarly high levels of education attainment. Both depression symptoms and loneliness were a little higher in those living with HIV versus those living without. So the results from our EFA-CFA, out of the 3 scales that we had, we identified 7 different factors, 1 at the individual level, 4 at the personal level, and 2 at the community level. So the global resilience at the individual level represents the psychological and internal resilience. For the interpersonal level, we had relationship closeness, reliability, confidence, and openness. And then at the community level, we had community belonging, which represents the extent in which a participant feels a part of the community, and then helping, the extent in which they feel like they are getting help within their community. Oh, and just to note that there were actually no statistical differences in the structure of the factors by HIV status. So we tested it both to see, doing measurement and variance to see if there was going to be a difference by HIV status, and we didn't find any. So all of these factors were then included into the mediation model. But first, I kind of want to go over what some of these associations were. So at time 1, all of the factors were negatively associated with depressive symptoms and loneliness at time 1. And then when we look at the relationship at time 3, we saw that individual level global resilience factor was associated with decreased odds of depression symptoms. And then at time 3, the interpersonal level relationship confidence and reliability were associated with decreased odds of loneliness at time 3. So the results from our mediation model, just overall, we found that the resilience factors reduced the effects, so completely mediated the relationship between depressive symptoms and loneliness. And then we found the same in the reverse with depressive symptoms as an outcome. Resilience factors reduced the effect of loneliness at time 1 on depressive symptoms at time 3.
So just very briefly, and we'll have an opportunity in the Q&A for sake of time here, I'm going to run through the summary. Multi-level resilience did in fact mediate the pathway between loneliness and depression symptoms as we saw in this sample. Individual level resilience was an important factor for mediating depression symptoms, while interpersonal level resilience factors in terms of relationship confidence and community belonging mediated loneliness. So we saw some differentiation there. This model of resilience supports the conceptualization of resilience as a process in which internal individual level factors as well as external factors at the social community level interact. The limitations and strengths, first, of course, this was an observational convenience sampling used for the max recruitment design. The sample did consist of mostly college-educated, urban, non-Hispanic, white, sexual minority, male minorities. So, of course, this limited the generalizability of these results. In terms of strengths, this was a well-characterized observational cohort of SMM living with or without HIV. We explored resilience, again, as a multi-level variable. Longitudinal design did allow for causal inferences on the bidirectional relationship between loneliness and depression symptoms. There are many implications for practice. Again, we'll have an opportunity to talk, but one of the things that I think was highlighted in this study is that to mitigate the risk of loneliness and depression symptoms, it's important to promote interventions not only that build individual level internal resilience among these sexual male minorities, but also increase opportunities to strengthen positive interpersonal relationships as well as community support.
Thank you.
Thank you all.